Mr. Chairman, dear colleagues, I will take you to another land after this interesting aortic session, the land of DVT, and we will speak about the management of DVT in a special group of patients, which is the fragile patient. First, we should know who are the fragile patients. Any patient with cancer considered to be fragile. Also, patients with renal impairment and patients with extremes of age are considered to be fragile. Why? Why these fragile patients are different? They are different because the efficacy and the safety of anticoagulation are not the same between the fragile and the non-fragile patients. There is more risk of VTE recurrence and more risk of bleeding. The treatment of DVT remained unchanged for more than 50 years, since the introduction of heparin and dicumarole in 1930s and 40s till the appearance of 𝗏𝑠 in 2011. And now, after more than 10 years of 𝗏𝑠 are no longer novel or no longer new. We have now a large volume of evidence and data about the use of 𝗏𝑠 in DVT. But what about the evidence of the use of 𝗏𝑠 in fragile patients? The Einstein study included a number of fragile patients, and by comparing the use of rivaroxaban versus standard therapy, it was found that rivaroxaban reduces the risk of major bleeding in fragile patients by 73% versus standard of care. A category of the fragile patient is patient with renal impairment. Rivaroxaban can be used in mild and moderate renal impairment, and in case of severe renal impairment, a reduction of the dose from 20 mg once daily to 15 mg once daily is considered. Here we can notice also that the rate of major bleeding in mild and moderate patients with renal impairment is less with rivaroxaban than standard therapy. Just a reminder for the dose of rivaroxaban, it can be taken from day 0, 15 mg twice daily for 3 weeks, followed by 20 mg once daily. Of course, it's taken with food. Why this 3 weeks loading dose? Because the rate of recurrence is highest in the first 3 weeks after the onset of DVT, so it is preferable to give long loading dose. Cancer-associated thrombosis. Overall, the treatment of cancer-associated thrombosis follows the same principle of the treatment of VTE. But as any fragile patient, the efficacy and the safety of anticoagulation are not the same. There is also more risk of recurrence and more risk of bleeding. In 2016, the ACCP guidelines stated that they suggested the use of 𝗏𝑠 over standard therapy in no cancer patient. But in cancer patient, they suggested the use of low molecular weight heparin over 𝗏𝑠. But this was in 2016. And now by the accumulation of evidence, all guidelines recommend the use of rivaroxaban in cancer patient. The evidence comes from randomized controlled trial and the real-world evidence. The 𝗓𝘂 study, it is a phase 3 pilot study comparing rivaroxaban versus dalteparin for the treatment of cancer-associated thrombosis. As we can find here, the rate of recurrence was less with rivaroxaban, and there is low incidence of major bleeding in both arms with similar rate of fatal bleeding. This was a randomized controlled trial. What about the real-world evidence? If the drug performance in the real world is the same as the randomized controlled trials, the real world is considered to be a scary place. The patients are older and sicker, and the care is not ideal. There may be under-treatment, underdosing, or overdosing. There is overuse of antiplatelets, and there is under-adherence from the patient. But of course, real world can be better. This is a real-world database analysis of an elderly cancer-associated thrombosis population. We can find here the rate of recurrence was less with rivaroxaban and the rate of major bleeding was similar in both groups, receiving low molecular weight heparin and receiving rivaroxaban. We all know the 𝗟lia study. It is a real-world study. And the rates of major bleeding and the recurrence in the 𝗟lia study were similar to the rates seen in the Einstein BE and Einstein DVT studies. And this gives reassurance that even in the broader community settings, rivaroxaban is behaving the way it did in the clinical trials. The International Society of Thrombosis and Hemostasis, they named the use of rivaroxaban and edoxaban in the treatment of cancer-associated thrombosis. But there is an exclusion of their use in GI cancer and genitourinary cancer, because the drug has a local effect on the GI mucosa, which may cause GI bleeding. So it is preferred in these cases to use low molecular weight heparin. To not forget, any case of idiopathic DVT coming to your clinic may be the first sign of a hidden malignancy which is not discovered yet. What about the use of rivaroxaban in extremes of age? The Einstein study established that rivaroxaban may offer improved safety and efficacy as an anticoagulation therapy in elderly patients. But what about the use of rivaroxaban in children? The Einstein Junior study studied the use of rivaroxaban in over than 500 children from birth to 18 years old with acute DVT. And they receive either tablets or suspension. And the suspension was in a body weight adjusted dose. And lastly, in December 2021, the FDA approved the use of rivaroxaban in children. And a new liquid version of the drug that the child can drink was approved also. But certain restrictions were still applied in a small body weight under 5.7 pounds or premature infants and less than 6 months old. After these data, we can say that this is the last chapter in the management of DVT, but of course, we will see what the future carries for these patients. Thank you.
Thank you very much, Dr. Amr. I want to ask you about the time of treatment and the need for extension of treatment for patients with acute deep venous thrombosis using the rivaroxaban.
Yes, the extension treatment, according to the guidelines, it differs if the DVT is idiopathic or non-idiopathic. If the patient if it is provoked or non-provoked. Yeah. If the DVT is provoked, it's recommended to be for 3 months, then followed by extension therapy. And if it is unprovoked, extension therapy will be prolonged. The extension therapy of DVT using rivaroxaban will be with 10 milligram once daily, after the dose of 20 milligram once daily for 3 to 6 months.
It is a fixed dose for extension of treatment, 10 milligrams once daily or 20 milligrams once daily? Or it maybe differs from one patient to another?
The dose of in extension treatment using rivaroxaban is 10 milligram once daily.
10 milligram
10 milligram once daily. The extension treatment. As an extension treatment.
No place for 20 milligrams once daily for extension treatment?
It will not be an extension treatment. It will be extended anticoagulation in patients with unprovoked DVT. If we have a patient with unprovoked DVT, the regimen of treatment will be extended anticoagulation. There is no definite time to stop his anticoagulation therapy. So okay, you can continue 20 milligrams as you decide as regards the patient condition. But as extension treatment, the dose is 10 milligram once daily.
I wanted to clarify that the loading dose is 15 milligram twice daily for 3 weeks.
Yes.
Then the maintenance dose is 20 milligram
Once daily.
once daily for 3 months.
Yes.
But if there is a fragile patient or he has a high risk of bleeding, he may receive 15 milligrams once daily for the 3 months. But,
yes,
but the extension of treatment, it may be 10 milligram once daily or 20 milligram once daily. It depends on several factors, the bleeding and the instance of thrombosis, a cancer patient, or whatever that.
Yes, but I totally agree, but it will not
Yes.
be under the name of extension treatment. It will be under the name of extended anticoagulation.
Yes.
Yes.
And for how long I can extend the treatment? 1 year, 2 years, forever? For how long?
The guidelines didn't name a duration.
Yes.
It take it to, I think it depends on the surgeon and the condition of the patient. And there should be a continuous assessment of the risk of bleeding and the risk of recurrence for each patient.
Excuse me, Dr. Amr, I want to ask a question. It's if you have a patient, or if I have a patient in my clinic, a fragile patient with DVT, and you know there is many NOACs in the market, and I respect all of them. So on what basis you want me to choose which NOAC to give?
There is no comparative studies between NOACs and each other. So every company says they are the best. And there is no data about a preference of one NOAC over the other as regard the efficacy and as regard the safety. So I have no data, and these are the data of the companies. So you can use 𝗓𝗏𝗃𝗃, you can use 𝗓𝗡𝗃𝗃, but there is no studies comparing these NOACs against each other to say this is better than this. So in fragile patients, you can use any of the NOACs, and there is no comparable data which is better than the other.
We have a question, Dr. 𝗙𝗿𝗄𝗆.
Thank you, Dr. Amr, for excellent presentation as usual. I missed just the first few slides, but talking about fragile patients, I'd like to know if you have any updates about using rivaroxaban in the children age group, and because some reports mentioned something of using it, but if you can update us if there is any update in this special group. The other thing, talking about the elderly, I wonder how do you adjust the dose to fit which age? I mean, when you receive a patient that's over 70 years old, how would you choose the right dose for that patient? Thank you.
Thank you, Dr. Ahmed. For the children, in 2019, the International Society of Thrombosis and Hemostasis, there was a presentation about the Einstein Junior study. And now, in last December, in 2021, there is FDA approval of the use of rivaroxaban in the children. As regards the dose, I don't know. It is weight-adjusted dose, but I don't know how many milligrams to be taken by the weight. And I asked the company, and they have no answer for this question. As regards the elderly, over 70 years, the half-life time of the drug is prolonged in these patients. So, my experience, you should decrease the dose in elderly patients above 75 years because they have a prolonged half-life time of the drug. So instead of giving 20 milligram once daily, you can give 15 milligram or maybe 10 milligram once daily. Also, this depends on the assessment of the safety and the risk of bleeding for the patient.
Thank you. Please.
I have a question about breastfeeding females during this period. Is it safe for them to take?
There is no data about any of the NOACs to be used in breastfeeding. I think the only drug that can be used in breastfeeding is warfarin. And I think Dr. Khalid and Dr. Mahmoud will agree with me for this.
It's not safe
Yes.
in pregnant or lactating females. And you have clarified in your presentation that rivaroxaban is safe in cancer patients. But I want to stress that it is very safe in cancer patients and recommended, but not in GIT cancer.
Yes, of course.
For fear of bleeding.